Thank you everyone for joining our session. As you can see, our today's topic is GIT Theory, Gastrointestinal Tract Theory. I'll tell you the specific things which is related to the exam. Our classes are based on AMC Part 1 exam. GIT in general is a vast field. Technically, even there is like MD courses available for GIT where people spend 5 years to become a consultant. So you can understand we have to go through like a specific things related to AMC, but in between we'll try to go through some of the related things related to clinical beginning, um, the pattern and way of asking question. Maybe I highlighted last day. If you see, like normally they give you a scenario with the age, chief complaint, and this that, and at the same time they will ask you what is like the next step of the management, what is initial step, what is the best management. They will ask you also about investigation, initial, next, best. This is how they can ask. They can also give you best approach that, like investigation and management, what to choose. We'll see that today as well. And also some cases specific thing can be asked, like they will give you which of the following is the biggest risk factor. Okay, so we'll see a similar question today. I'm telling you so that you understand the patterns actually, especially in AMC, understanding the pattern is very important. One is exam preparation or studying disease on is understanding the pattern. Those of you will understand the pattern and read the relevant diseases according to the pattern, the higher the chances of the success actually. Many people think, okay, I'll just do 1 year or 2 year, I'll pass the exam. These are just not gonna work in AMC. You need to have a certain basic at the same time clinical skills, and of course with the classes we'll tell you the techniques, and all together you will definitely pass the exam actually, we strongly believe. And I hope so, I mean by end of this year you all will clear the exam, if not by end of this year, next year beginning. And I mean I strongly believe you all will um, pass the exam actually. So with that note, let's go and start. Let's see what's coming up for us. If you just now joined, please open up John Murtagh 440 page. And yeah, open John Murtagh, use a laptop and a headphone. And of course, we are interacting through the Zoom. Some of you put some inquiries in respiratory. If you have more inquiries, definitely we're going to see that. After to the session, I mean, I'll be taking a respiratory mock actually, the first of the mock. I hope so you have prepared well. It's a more like a manual mock. We'll talk about it after the class actually. Okay, so here we go. Books, recalls, key points. Books in terms of we'll be using the John Murtagh, and for the theory, please, we will be using the SMA notes side by side. You can keep books like Davidson or Master of the Board, whichever you like. You can keep in a side. You never know sometimes which point from one book can be useful for you. And of course, recalls. Last day you have seen the pattern. We have gone through theory, then we have gone through the recall, and we highlighted the key points, which is like a 5 star for the exam, which on and off come in our exam MC part 1 on and off. Yeah, so a very big question, have you seen the overview of the GIT? Please comment in the comment section actually. All right, please comment in the comment section. All right, so have you seen, so you get an idea what are the topics we're going to, like say, from this side to the to we'll be covering some of the parts related to the surgery like intestinal, some of the obstruction things, hemorrhoids. Those are like part of the surgery, so those things we're not going to do here. But like esophagus, stomach, and many things related to like a intestine we'll be also doing today as well. All right, so these are the pillars we call it actually. Example, you need to have a very solid foundation, like reading the theory, then solving the recalls, then solving the mocks regularly, and going through the question banks. Yes. So these are kind of like that, 4 or 5 pillars actually. Yeah. So, and of course, group discussions actually, another pillar. I mean, so theory, recall, mock, question banks, and actually the discussions. Now, where you can do discussions. One, you can have study partners from this group. So today, probably after the class, or maybe after the next class, we'll post in the group to find a study partner hunting process, kind of like that, you can say. So you can keep trying, find it out a study partner from this group or someone who is taking classes, it will be more easy. Do not try to find out who is already not studying or not following this one, and then it will be difficulties for you actually. So some sort of similar caliber. A special tip: if you are from a country and English is not your primary language, or something like day to day you don't speak English all the time. So in that case, what you can do, you can take a cross country study partner. Say someone living in Bangladesh, you can take a study partner from Sri Lanka. Someone living in Sri Lanka, you can take a study partner from Bangladesh, or it's vice versa, like Pakistan, India. Anyone can make any. It's good for in terms of speaking. It's good for in terms of taking your English to the next level. It's a good idea. I'm telling you this thing actually. A lot of people, when they finish, they have difficulties in this case actually. As we mentioned, class to class, you will understand. Normally, we study the John Mutta, whatever I'm telling, please read those part first of all. There's no harm if you want to study extra. That's totally up to you actually. But there is nothing like in medical sense. You cannot tell like, all right, this is 100% this that. But we can speculate. So normally, the highlighted one is a priority. Imagine like now you are seeing syllabus like this. Imagine the syllabus after 5 months. Then this highlighting part should be even more than for you for revision. Am I right, guys? Please comment in the comment section. A little participation I appreciate actually during the class. All right. Like now, whatever you are studying, I mean, at the end, understand one thing, whatever you're doing right now, lastly, you have to revise everything. All right. So that's the thing. Great. Very, very important thing. We'll take the mock after finishing the class, actually. Thank you. All right. Now, here we go, like the question banks and the choices and this, that. So there's a lot of question banks available, actually. Um, Amadeus, Influx, MCQ bank, anyone you can pick up. Amadeus is being trending, actually. So maybe you can go through. So one question bank is enough. We'll post some of the question bank. No need to take extra subscription in that cases, actually. Don't miss our live classes. So good luck, definitely. I mean, uh, evidence-based thing, let me tell you, I mean, I can certify that one. Those attending live class and after class, they're having discussion, or sometimes they take recordings, but mostly they focus on live class. Their results are spot on actually. But those people are not attending live classes. That's telling, oh, I have duties, this, that. They cannot manage. Everything is manageable in this world actually. So if you can't manage, then maybe you can't manage to pass the MC exam. That's on you actually. If you're missing classes regularly, that's on you totally. All right. That's the thing actually. All right. Great. Now, next thing is coming up is a GIT, and another one is a esophagus actually. Yeah. Yeah, mock test will post the question. It's a manual. Guys, please focus on the class. We're not talking about any mock things right now. Okay. I don't want to see anyone mentioning about the mock anymore here. Okay. When it will be time, I'll tell you actually at the end. All right. Great. Okay. Now coming to the thing. I mean, see, understand, I need to be focused. If my focus got hampered, the whole class will be affected. All right. Now here is the thing. When we talk about the GIT, of course, we start with the esophagus. Now no one will comment anything actually. And please focus. This is a time to be really focused actually. So esophageal things, stomach related things, intestinal things. Yeah. So some of the parts, yeah, like can be related to the surgery, like anal part and some of the intestinal part. Questions related to surgery actually. So it will finish in surgery. So but a lot of esophageal disease, stomach related things, intestinal related things will do definitely today. And some of the miscellaneous things will be also seen today. Now, I'll be telling you the bullet points, necessary things you need to mark. Read the marked one in the John Murtagh. Try not to do the unusual too much studying others. But you can have a look actually. I don't mind on that one. It's like a nice tool, that other parts actually, which is not discussed in classes actually. Okay. In the classes, we'll be also talking about sometimes radiology. Please also focus on them actually at the same time. Maybe probably by end of the class, I'll give you a little guidance about where to find the radiologists actually. We do have a video channel where there's a radiology album, and maybe at the end I'll give you some ideas about that actually. All right. How to take the exam? Um, so after class, you'll take a pen, paper, and something, and at the same time you'll mark those things, and I'll tell you actually, so in that case, you take a picture as quick as possible, and there'll be the question answer thing will be posted in the group, both of them, the question and the answer sheet. You can download later, and your answer sheet, you can check by yourself, and at the same time you post actually. The big computerized exams, of course, we'll be taking later actually. Like those are, I mean, you are not, of course, prepared for the 150 questions right now. Actually, those I'll be taking the computerized one at the end. For now, every week we need to pressurize you. So you need to go through the smaller mocks now, actually, which by the end, I will tell you actually. All right. Now, in the classes, about the recording, some doctor inboxes like this is a live batch. So mainly there is not supposed to come recording, but we still post the recording. And usually we give you a 48 hours to rewatch them. In that way, you will be staying in your toes actually at the same time, actually. Great. Okay, no problem. So if you have a Sunday class, you upload the recording on the Monday. Monday to stay enough time to finish a recording. Actually, it's more than enough. If you're not comfortable with this thing, we do have a whole recorded course. You can go and switch to the recorded course, actually, which is more like Netflix, actually, ready-made course, actually, but it gets updated month-wise, actually. Okay, so it's kind of like monthly, it's like every monthly, we update the, say, medicine only. After finishing medicine, you update the medicine. So you do have courses also like that. Great. Are we clear so far? Because in the beginning, so in the this early stage we give you some ideas and this that, so this is important. Okay, but trust me, I mean, I do a lot of researches, and this is the best possible way. You come to the live classes. If anything missed, you check the recording. Some rare cases you miss the live, then you see the recording. Best possible way to crack the AMC. If you have this thought, you're a big consultant, this that, I don't give shit about that actually. Okay, I respect you, but that doesn't gonna work for passing the AMC. You come here, you come as a student. Actually, don't tell that I'm a consultant. This give me a special favor. I don't see those things actually. Till that in 9 year, I didn't see these things actually. So I respect you as a doctor. Anyone who's a doctor, I respect. Doesn't matter consultant. I myself is a consultant, so it doesn't really matter. So thing is here, uh, you need to give utmost respect in the classes. Whatever been told, I'm a trusted teacher. Been 9 years, highest rated uh, rating. Forget about that. Like I also win some awards and this that. We're not going there, but you need to trust your mentor very much. Especially, this is one condition I'll be requesting all of you to come to live classes. Yes, you can miss a small portion, still you try coming to the live classes. And in that case, something you missed, you check that recorded part, or you check the full initial days actually. Okay, initial days you can attend the live and then check the recording. As the time progresses, you try to finish everything in the live classes taking notes, so that you don't have to go through the recording. Rather than the another day, you can study, rather the better word. Okay, so this is important. All right. So if you're a doctor with emergencies and Sunday, Thursday, always you have classes, we have a course D that particular time. Still you have time, you can switch into that particular type of courses. Is more like Netflix type of media, we could say. Great. If you have questions about course D, you can inbox me, my messenger later. After the class, we'll talk about that. Actually, right. So here is the tip, study tip. Finish John Murtak. Those I'm highlighting are those topic I'm mentioning. Again, I'm telling this is a commonly asked question, doctor. Will I study the diseases you're mentioning? Yes. I mean, these diseases I'm mentioning. That's the thing. And then do more recalls. Then there are forum like Shahriar Sensi guideline. You can check more recalls there actually. All right. And finish recall if possible. I mean, you see, last day we posted the respiratory recall file. So I appreciate if you can take a print out and keep it in a file. It will be really nice. Start taking your own notes and also follow the SMA note. Some people ask question this thing like, is SMA note downloadable? No. Of course, it will start selling the immediate next day in the market. So we don't allow those things actually. All right. So focus on your body language. So please be seated. Sometimes I can turn on your video. Okay, so be careful on that. Okay. Other day, I mean, I opened up in last batch, someone was sleeping actually. No, so those kind of thing, not really appreciated. So when you are here, make sure, so you are really important. Great. All right. And use laptop, headphone, come in proper way, best way of learning actually. All right. All right. So this is our WhatsApp number. You can text here, or best would be you can send by messenger, actually, if anything related to the course actually. And class related inquiries, if you remember, I opened a respiratory inquiry zone in our particular batch 62. And some people ask me questions there actually, so I answered back there actually. So that is how I communicate. My messenger is full of so many things, so I personally don't always check them, but you guys are important. So you guys ask me class related question in the inquiry zones. Okay, so it's more specific for me. I knew that where to go to see your important questions actually, because in messenger, see, being a popular tutor around the world, many people they keep texting. All right, so it's things get difficult for me alone. So my team also manage my messenger, WhatsApp, lot of things. But the inquiry zone is mostly related to directly. I'm solving those particular thing in the inquiry zone. Okay, so far is it loud and clear, guys? Okay, so summary. While I'll be taking classes, you'll be also listening properly, sitting by not sleeping. Actually, great. All set. Ready? Please open page number 440. All right, everyone, let's get into page number 440, 439. The chapter is dyspepsia. We are ready to go. All right. It's all set for dear doctors. Okay. Now, speaking about the GIT, so gastrointestinal tract, as you can see. So from this particular area to esophageal, stomach areas, duodenum, small intestine, large intestine, and somewhere rectum, anal canal, and all these things. Great. Now, speaking about some of the parts, is speak about this thing. That's the esophagus. Now, before going into esophagus, can you tell me about some important diseases related to esophagus? A very popular one, a very, very popular one, and often we learn differentiation, GERD and the Achalasia. By the way, esophagus related, most of the things we remember as dysphagia. Then there's another thing, dyspepsia. Then you will find nausea, you'll find vomiting, but you will also find some sort of bleedings. Am I right, guys? You'll also find some sort of bleeding from the esophagus. Is it possible? Definitely, it's possible. Okay, definitely possible. So dysphagia, dyspepsia, nausea, vomiting, bleeding. Okay, these things. Also, is it possible like a some sort of obstructions in this because like as like a stricture, so food cannot be passed. So these are the in general thing can happen, right? These are like some of the symptoms. Okay, now let's focus on the diseases. ZRD, achalasia. Quick question: is both of them associated with dysphagia or not? Possible? Yes, both of them is a possibility of having dysphagia. Not maybe not as an early symptom, but that's a possibility. But mostly they are esophageal conditions actually. Now, one of them will be related to somewhere heartburn, and one of them it is not. So GERD is mostly related to heartburn, whereas achalasia not. Achalasia at the same time can be related to dysphagia to liquid food. Okay, initially. And GERD, dysphagia to initially could be solid if associated with any stricture or a cancer. Actually, we'll talk about it more details. Actually, I'm just telling you what are some of the important. Now, can you tell me more diseases, guys? Can you tell me more diseases? Now, if this like more changes, GERD can be turning into Barrett's. Esophagus area can be also having infection or inflammation or ulcer, can relate it to esophagitis. Barrett's and many other condition can be turning into, or genetically there can be esophageal cancer, esophageal cancer. Now, some of the condition can be related to extreme vomiting situations, extreme vomiting situations, like ulcer conditions is one of the thing. But tell me about the vomiting condition. So in that case, Mallory-Weiss, Mallory-Weiss syndrome. What else? If you are talking about the Mallory-Weiss, another name should be Boerhaav's. Okay, we name these two together. Like often when we study Mallory-Weiss, Boerhaav's, we study together. GERD, Achalasia, we study together. Now, one of the condition which can be allergic, esophageal allergic condition, esophageal allergic condition, which is a eosinophilic. Have you heard this name? It's important for exam actually. Eosinophilic esophagitis. Even last month, it has been tested. Eosinophilic esophagitis. Okay, and then there is a situation which is related to general livers, like example, uh, varices, which can lead to bleeding as well. Okay, which can lead to bleeding as well. Okay, and things can be narrowed down and can lead to, stricture. Things can be, stricture, and also you can say esophagitis, esophageal ulcers, ulcer or esophagitis. Now, are you in general clear about these things? 1, 2, 3, 4, 5, 6, 7, 8, 9, almost like 10 conditions. All clear? So these are the things maximum so far has been tested in AMC. Trust me, you'll not find anything outside this actually. All right. You can add in another one, like say 11. We call it sometime esophageal motility disorder. Now, actually, Achalasia is under this one, most of diseases, but and some systematic diseases. Can anyone name at least one? Like motility problems. So when there is a stomach motility problem, dysphagia to liquid problem comes first. So yes, systematic sclerosis, rheumatoid arthritis. These are some of the motility related disorder. I mean systemic disorder, actually. But original OG is Achalasia. Okay. Is this so far a good opening? Is it important that, when you play cricket, the opening is very important, isn't it? I mean, those of us, those of you who follow cricket, the opening pairs are important. So the opening is always important. Now let's get back. Headlines are done. Now let's get back to 443. Let's take a jump here, guys. Let's take a jump to the 443. This is gastroesophageal reflux disease. Give a 5-star, or you can type the word 5-star here. Now highlight these lines: bloating, heartburn, nocturnal cough, and many other things can be even water blush. So heartburn is very common. Now, statistics are important. I mean, statistical informations. 40% of the heart 40% of the like chest pain often ended up with simple gas problem. What does it mean? Like it looks like heart attack, but later ended up with a gas problem. Did you heard situations like that? Yes, like thought about it, it was heart problem, not turned out to be a simple stomach problem, esophageal problem, gas problem, many. Okay, so the status is actually 40%. It's quite huge actually. And the more important one is a GERD. Most of the cases, these people are obese. So please highlight this line. These GERD people are often obese. Then having bloating, heartburn, and nocturnal, and near to the heartburn, please write versus achalasia. Now I'll draw something for you. Let's get back to the drawing part to make you feel good. All right. I hope you're not bored. Okay. Now this is part. Esophagus we always divide into part two, third, and lower one, thing like this. Okay. Our topic of discussion is GERD, gastroesophageal reflux disease. Now, this is a normal case. Now, this is another area where there is backflow. The door is supposed to close at time, which we call the sphincter. If it is not closing in time, the acidic environment in the stomach is like backflow. Is it good? No. This area will get affected. This is we call reflux. Reflux. Okay, it is called. So the question is, in GID cases, is there a possibility of the heartburn? The answer is yes. Heartburn, yes. Associated features like bloating, nausea, water blush, all these things are associated feature, and often they are quite obese people. Okay. Most important thing in case of AMC is what is the specific investigation related to GERD. I hope you're understanding what I'm saying. These are important things, and what is the most important initial investigation related to GERD, and it's a variant. Okay, understand one thing. Most of the all esophageal cases, not only GERD, all esophageal cases, our initial test is mostly variant. This is a secret tip. As like in the chest cases, respiratory cases, do you agree? Most of the cases was chest X-ray. I'm doing a little compare contrast. Yeah, so to understand. So respiratory cases, we mostly go for the chest X-ray. And here we are mostly going for esophageal cases, barrier. Now, we're talking about the GERD, this is our disease. What is the confirmatory for the GERD? If I'm hearing the right, the 24-hour pH monitoring, 24-hour pH, this is the absolutely correct answer. Okay, so you need to remember this is again 5-star for the exam. They'll give you a scenario, someone who's obese, heartburn. I mean, age is more like 40, recently getting a lot weight and having bloating features after eating, feeling more discomfort and sweating. So this is a very classic for the GERD. And now these are the tests actually. Now, speaking about management, speaking about the management, what management you'd like to do? Now, answer is of course lifestyle modification, which is a long term, but you need an initial thing. So initial is a PPI, PPI 20 milligram. Now, here is the thing, and last day in the recall class I asked. I repeat, last day in recall class I asked. Now, if 20 milligram is not enough, what to do next? 20 milligram not enough, what to do next? So next here is a PPI 40 milligram. And as a long term, what is the long term treatment of GERD? It's a lifestyle. Lifestyle, perhaps best would be weight loss. Okay, so these are important. So treatment, these are some of the treatment, diet modifications. These are very spicy. If you eat too spicy, oily, you'll be out of trouble. This is important. So PPI, and next is a 40. Now, this brings us to a very important question, a new pattern. They will ask you, what is the best approach? Please check the question only. What is the best approach? Now, they will offer you a barium, they will offer you PPI. Which one do you think is correct? They're asking something which is an approach. It can be an investigation, it can be an barium actually. Normally, we go for the investigation first in most diseases, but this is one of the exception why we are going for. So clear winner is a PPI. So we'll try the PPI, we double the dose of the PPI, still not working because the GERD diagnosis, we can make the diagnosis clinically often initially, but later, if necessary, we'll go for the barium and later 24-hour pH monitoring. Is it clear to all the doctors so far? Is it clear to all the doctors so far? Okay, if you are clear with this part, then I'll talk about the some complications. When you are continuously hitting your lower part with some acid thing, did I say the right thing? Is that an acid which is hitting your lower part in GID? If it goes continuously, is it possible it can give rise to uh, some sort of irritation and some sort of changes like esophagitis initially as a complication? Is it possible esophagitis initially, irritation, and then it can lead to Barrett's at some point? Okay, so our one of the another important thing is Barrett's actually. Barrett's we'll see in John Mutta, but let me tell you the most important thing from the Barrett's they will ask you. Barrett's is a pre-malignant condition and it is a two-edged sword as well. Pre-malignant condition and it is like a two-edged sword. Two-edged sword. So in case of Barrett's, if Barrett's developed in future, it can lead to some sort of um, adenocarcinoma. It is possible in case of it can lead to some sort of adenocarcinoma. So that is one of the reason you need a strict follow-up. So what is the follow-up procedure in this case? Best cases, follow-up is very, very important. 5-star for the uh, exam. So we'll do the follow-up, followed by endoscopy. What kind of follow-up? Followed by endoscopy and biopsy. Now, how persistently we do that? We do that every 2 yearly. I'll show you in John Murtagh these particular lines, but these are in general things about the GERD. Okay, let me know in the comment section. Do you like drawing things in the classes? I mean, just taking your opinion. Do you like drawing things? And at the same time, I'm marking it actually. I find, I mean, doing both simultaneously helps most of you. Okay, now it will look more easy. Now we see already heartburn and versus heartburn, achalasia, nocturnal symptom, because when you sleep, more acid comes out. So it's like a nocturnal cough. Okay. And in terms of investigation, we do have barium, we do have uh, uh, barium 24 page and the endoscopy. Now, when is the answer endoscopy? Is endoscopy is the initial test for endoscopy? Is it the initial test for GERD? My quick question, please understand the question. No. Answer is a no. But some cases endoscopy is a priority when there are red flags. Red flags means what? Red flags means if there is a dysphagia. Dysphagia associated with GERD, is it a good news or bad news? The people cannot, take the food properly. It's a bad news in GERD. It means there was so much acid reflux, there's like a so much stricture and esophagitis maybe at the next level something. So dysphagia and GERD indicating some bad prognosis actually. So in that cases, endoscopy. So you see many other condition like vomiting means there is also some sort of obstruction because of a stricture. Okay, so if these things are present, in that case, you can go for a endoscopy. Am I clear, guys? So again, coming to the investigation section, normally barium initially, then 24-hour pH. This is confirmatory, but if you have the red flag in the question, this is a 5-star question. If you have red flag like a dysphagia, like iron deficiency anemia, or they're talking about bleeding, then you will go for the endoscopy. Is it loud and clear so far, everyone? Guys, going through the John Muttar, going through the drawing part already, and you can see GORD, same thing. Reduce weight overnight. This is long term. Just write the word long term next to this. We're at page number 444. Also avoid some drugs that can also cause, some esophagitis. So you should try avoid this thing, including very important NSAIDs actually. Okay, and here is the line. Please highlight it and write this thing. Double the dose. Highlight this line, page number 444. Double the dose. Last day we also read another doubling the dose. This is a test of your memory, guys. Last day we discussed about um, another specific doubling the dose, which is in asthma cases, using salbutamol. If 6 years or more than, something like that, we can repeat like a 12 puff. We can repeat in 12 puffs. So this is how, if you compare, contrast, and study, very high chances that, you will be memorizing a lot of things in that case. All right. Okay. So everyone is clear so far up to this for GERD? Please mention in the comment section. Great. If you understand GERD, please understand there's another disease which is a bit related to GERD is the hiatus hernia. We will talk about hiatus hernia more in the surgery though, but you can remember it like GERD and hiatus hernia has very strong association actually. Okay, GERD and hiatus hernia has a strong association. Another systemic disease GERD has association is asthma. 30%, according to Davidson Medicine, 30% of the GERD cases are associated with asthma. Is it clear, dear doctors? Great. It is wonderful. It is wonderful. Let me ask you an interesting question. What do you think one of the commonest um, ulcer or commonest GIT problem, I would say? One of the commonest GIT problem. Answer is like a peptic ulcer disease. You are thinking, but it's a wrong answer. Okay, you must be thinking this is coming. Correct answer is a non-ulcer dyspepsia. Now, how many of us are having ulcer? Not really. What we have sometimes discomfort, but is that a peptic ulcer? Understand? Ask yourself. I mean, do we have like classic peptic ulcer, like a duodenal point tenderness and all this? No, we don't have this thing. But sometimes maybe some of us has gas problem. Is that a typical peptic ulcer? No, that is a non-ulcer dyspepsia. Okay, so you see, so statistically, 60% of the people are suffering from non-ulcer dyspepsia, which is very most common out of everything. Okay, I'd like to ask a tricky thing, which is maybe an extra thing, so to test of some of your depth of knowledge. H. pylori can cause a lot of things, right? Now, H. pylori associated diseases. Let's see how many names you know. Now, it started with two things: duodenal ulcer, gastric ulcer. What else? Okay, nice one. If you say esophageal cancer, right? Then, okay, lymphoma, maltoma. Don't forget gastritis. Don't forget gastritis. Can we also add non-ulcer dyspepsia? Can we add that? Also, Zollinger-Ellison syndrome. Don't forget that. Zollinger-Ellison. Yes. Another one, I think, if I'm not mistaken, antral stomatitis. Have you heard this name? Maybe long back in pathology. Okay, great. So just a idea, sharing a thought. Now we're talking about the GERD, and another one condition was a Barrett's esophagus. Did I mention there's 2 yearly follow-up? Please highlight this one, and this is 5-star for the exam. So you can see another pattern in AMC is asking the follow-up time. Did you realize that? They also would love to ask, giving a disease, the situation, what has been done, and how persistently we are following up this thing. So this is surely they're gonna ask you in the exam. So consider 2 yearly endoscopy with biopsy, right? So diagnosed with endoscopy and biopsy. Barrett's esophagus, two-edged sword, pre-malignant condition. Pre-malignant means about to have malignancy. Now, I'll tell you a small mnemonic about this thing actually. So sometimes we called one third AB. And what is that? One third AB. Now, if you remember, we divide this esophageal thing into two half, lower one third, upper two third. Now, upper two third is mostly related to squamous cell carcinoma, and the below one third is adenocarcinoma. Below one third is adenocarcinoma. So one third A, B, I remember. So adenocarcinoma, lower one third, B for the Barrett's. Okay, so this is the thing. Another thing, mnemonic to remember, BCS. Now, in our country, BCS is popular. BCS is more like a doctor who is getting into the government job. What is it in your country? It is called. Do you have something like BCS? In our country, it is called like a BCS cadre or something like that. I'm sure every country has like a government uh, replacement or something like that. I think another class, I think last batch I asked, they said also PCS, civil service. Okay. I mean, you have to study outside the medical syllabus as well to get into those posts. Quite weird. No, yeah, PSC, I think. Some people said, yes, great. Anyways, now why I'm telling this, a mnemonic in Barrett's, I hope you're writing. Keeping a notebook and something is very in Barrett's. Columnar replaces squamous. So normally it is squamous, but replaced with columnar. Now, is this changing is good? Is this metaplastic changes are good? Not really, actually. And that is a potential for having a cancer. That is a potential for having a cancer, actually. Okay, so the mnemonic BCS in Barrett's, columnar replaces squamous. Columnar replaces. So B, C for columnar, S for squamous. Cool. Understood, everyone? So I think we covered almost everything regarding this Barrett's, regarding GERD, regarding some of the things related to hiatus. Hiatus will be again discussed in surgery, by the way. Okay, good. Okay, wonderful. All right. Let's see what we have. All right. Taking a little time. No worries. Okay. So here is a chapter we have 450 page. I'd recommend you to open. And here few things are given. The causes of dysphagia. So functional dysphagia, okay, whatever it is. And you can see here. Basically, I remember as a dysphagia to solid and dysphagia to liquid. These are the two lines you need mainly for the exams or any competitive field. So dysphagia to solid, mostly it applies to strictures and if there is, tumor, 450. Our page number is always displayed here. Yes, down and bottom. Lower left corner. Okay, great. Now, here is the thing that in case of dysphagia, the one I was telling solid like a mainly stricture and the tumor like esophageal cancer. Now, can anyone tell me dysphagia to liquid? I think earlier I said. So dysphagia to liquid is like the motility disorders, any motility disorders. It means the achalasia and some of the systematic condition, but mostly you will remember the achalasia, which is popular in the exam. Right? Now we move forward. Here's few key lines. Maybe if you want to highlight them, dysphagia for liquid solid typical, okay. Achalasia. You can just give it tick, later you can highlight. Three big threes, yeah. Then peptic ulcer, cancer, achalasia again. Intermittent dysphagia for solid liquid again in achalasia. So the thing is actually intermittent dysphagia, they mean to say the dysphagia to liquid started initially. Then there will be both liquid and solid problem. This is again classic for esophageal achalasias. Achalasia. So I highlighted those particular line. Red flag for any dysphagias. Please highlight. Just give a tick to this one, including if you think about the weight loss, if you think about the classic dysphagia, dysphagia for solid over 50, these are the red flags. Okay, skipping this part. These parts are mostly for the MC clinical. I mean, this 1-2 pages. Okay. Now we are getting into the part with the achalasia. Now we're getting into the part related to achalasia. So I'll be taking the screen for a second, just to bring something for you. Okay. Now in achalasia, can you tell me the major symptom, guys? Achalasia cases, can you tell me the major symptoms? Wonderful. Okay, we are back. Now I'll try to start showing a picture. By the way, guys, GIT related notes are available in SMA notes section. You can also follow our SMA notes in that case. So mostly here I'm trying to follow the books, but all these topics also do have some notes, actually, important ones. Okay, now this is what? This is a picture of a barium. The picture of barium, this is like a bird beak or like a rat tail appearance. Okay, so this goes with the achalasia. My initial question was, what was some of the clinical feature of achalasia? Like heart is not a feature. So dysphagia, it can be a feature. So achalasia cases, difficulty in solving, regurgitation or anything, like some cases, it can give rise to chest discomfort. All right. Okay. Let me show you a drawing. No worries. If you remember the previous picture, I draw a picture with a relaxed esophageal lower end or sphincter. It was loose, so there was acid reflux in last time. This situation is total opposite. So we do have a tight sphincter. Now, do you think heartburn will happen? The answer is a no. So this is the biggest difference to differentiate GERD and achalasia. So there is no heartburn usually in achalasia. This is the first thing actually. Second important thing in the MC, dysphagia to what? So in GERD cases, it's a possibility they will give you dysphagia to solid. It's a possibility, but those are in, uh, I mean, information. I mean, dysphagia is not so common in GERD in the early stage. But in achalasia cases, GERD, that dysphagia to liquid. So here is that line, dysphagia to liquid followed by both solid and liquid. So dysphagia to liquid followed by both solid and liquid. Did you understand the two major differences of achalasia and the GIT? One is a heartburn and one is this dysphagia thing. Dysphagia to liquid first. Dysphagia to liquid first. Okay, these are the lines I'm highlighting again and again because these will be given in your exam question directly. All right, that's the thing. Because they have motility problem, that's why the liquid problem first actually, because they have the motility related problem actually. Okay, now coming to the more like analysis, why this kind of problem? You see, imagine this is the histology. I mean, long back we learned about the histology, and in the histologies, actually, there were a lot of slide and the sections. Um, okay, now there are a lot of layers. If you remember, mucosa and the submucosa. Now, submucosal layer has a plexus called. It is called myenteric plexus. Submucosal layer has a plexus called myenteric plexus, isn't it? So myenteric plexus, this can be affected in case of this achalasia cases actually, or acquired cases by trypanosoma. You know, acquired cases, it can be damaged by trypanosoma, some cases, or it's a possibility a newborn is born or whatever. In that case, again, this myenteric plexus can. Now, why I'm talking about myenteric plexus? Because myenteric plexus is the plexus which helps like neurological, that particular movement. That is the motility movement. So can we say because of meningeal plexus affected, esophageal motility is affected and dysphagia to liquid shows up. Are we clear, guys? Meningeal plexus affected. Meningeal plexus related to motility of the esophagus. Now, if motility affected, so dysphagia to liquid. So when you drink the liquid, it does not go away properly. Right? So this is the initial finding. I hope that's clear. Speaking about the trypanosoma, more available in the African areas, actually. African areas. Now, interesting question. Same thing like the GIT. What is the first line in case of first line investigation in case of achalasia? Again, the same formula, that is the barium. Same formula again, that is the barium. Next thing, how to confirm? What is the next appropriate or how to confirm? Same thing. Next appropriate or how to confirm? So in that case, it would be manometry. Okay, coming back to John Murtagh, as you can see, motility disorder, the drawing already done. Let me show you the drawing again one more time if anyone wants to take a screenshot or whatever. Yeah. So this is a drawing part, motility disorder, investigation already mentioned. Going into the management now, actually. So tight esophageal sphincter here. You might see chest discomfort as well, confirmed by further manometries. Now, speaking about the treatment, conservative, dilator, Botox, and the surgery. Initial is barium, no doubt actually. Initial things are barium as investigation, manometry as a confirmatory. Now, in the treatment, initial is again conservative treatment. Conservative treatment. Now, in conservatively, like some of the lifestyle thing, and at the same time, some drugs like nifedipine and these things you can do. Now, you can understand this is a narrow or tight sphincter. Now, you need to make it dilate. Now, how we can make it dilate? By using a dilator, by using some sort of dilator. It has a name. Has anyone heard about Heller's dilator? I hope so you do. If you don't, just write it. Heller's dilator. So by the dilator, you can dilate. Some cases you can use the Botox, which is popular for using in the face to, if there is a wrinkle and after using it, it looks more tight actually in that case. Yeah. So the Botox, that particular technique has been used here actually. All right. Okay. For a specific muscle group, you can use that one actually, but mostly conservative, dilator, and the surgery. Last question. The surgery name is a myotomy. Five-star question here is which one of the following is the most effective treatment for achalasia? This was the last year exam question. Which one is the most effective treatment for achalasia? Answer is a myotomy. Now, even the myotomy is the most effective, but the mortality rate is quite high. So please write this line. But the mortality rate is high. Remember, two areas surgeon does not want to operate actually. Surgeons really don't like these two areas. One is a esophagus area. Very bad, very dangerous. And what is that another particular area? Like any general surgeon, they'd be like, no, brain is easy. I mean, they're crazy. They want to always drill into the brain. Ask any neurosurgeon. They're always ready to, enter into the brain. Very enthusiastic. You see Grey's Anatomy? Just a fun effort. But yeah, it's not that difficult. All brain surgeries, they're expert. Another area is the biliary and pancreatic, very complicated and sophisticated. Biliary and pancreatic, actually. Okay, those surgeries are the same thing. The pancreatics ones, actually. If you say just gallbladder surgery, that's a easy one. But if it's that the additional one, that's a difficult actually. And the additional one is difficult actually. Yeah, pancreatic surgeries are quite difficult. So, and it carries higher mortality rates as well. Okay, say if someone has cancers like cholangiocarcinoma, say cholangiocarcinoma, something like this. In that case, what to do? At some point, I mean, you will try to do the surgery and remove those particular part. Otherwise, already prognosis is bad. So you have to remove a lot of things in that case, isn't it? Like going through the ripples and this type, very complex surgeries. Okay. So the two important diseases are gone, GERD and the Achalasia. So in the inquiry zone, when I will be opening for GIT, please remind me to upload a differentiating chart for GERD and Achalasia. I'd like to post that one actually. Great. Now coming with the esophageal functional disorder or dysphagia to solid. Name one special disease which is related to dysphagia to solid. Name one particular disease, dysphagia to solid, and there will be weight loss features. Okay, so that is the thing. Some people ask, where is inquiry zone? Inquiry zone, we created in that Facebook group actually. It is mentioned like a respiratory inquiry zone, GIT inquiry zone. GIT inquiry zone will be created after class. Okay, please understand. Okay, so esophageal cancer. Okay, quick question. What about the prognosis? Good or bad? Esophageal cancer. In general, think about all cancer. Prognosis. Always any cancer comes. Think about the prognosis. Prognosis, very bad. Most cases. Depends on grading, staging, but in general, bad. Why I'm telling in general bad? Cancer, do you see as cancer now? Or do you see the cancer after, situation after 5 years as well? I mean, whether from here the person can survive or not. So cancer now and cancer after. So always remember cancer now, how we are dealing with it, and 5 year survival at the same time. I mean, whether the person gonna make it up to 5 years. So 5 year survival. Many people like comes with lung cancer, but even after treating, and like even 1 year they don't survive. Why? Because the 5 year survivability is poor, right? Classic. So dysphagia for solid, please highlight this line, then there can be hoarseness. So we someday we'll go to the ENT class, you'll see one of the very important differential is esophageal cancer versus laryngeal cancers actually. You'll see that actually. So hoarseness, hoarseness. Okay, great. Associated features like it can be GERD, smoking, Barrett's. This can lead to esophageal cancer or any particular family history. Okay. Now, again, initial investigation, again, barrier, because it's the test for all esophageal things, and then confirmatory by confirmatory by endoscopy and the biopsy. Because remember the red flags earlier, that's why you do the endoscopy. This is the reason we do the endoscopy to rule out what? Rule out the esophageal cancer. Correct? All right. So already mentioned earlier, but still I like to enter into something to show you. Yes, in this particular part. Now, speaking about esophageal cancer, some people write esophageal with the E, some people esophageal cancer. Now, one third AB. So, lower one third is a area for adenocarcinoma. Upper two third is the area for squamous carcinoma. Now, which one is more common in the whole world? This is a 5-star MC question. Somehow is a population health question as well. Question is, in the whole world, which one is number one? So this is actually worldwide. It's a 5-star, guys. Please put 5-star here. 5-star. Adenocarcinoma, on the other hand, MCC, most common in Australia. So this was another question, interestingly, according to RSCGP. According to RSCGP, this. According to RSCGP, number one cancer in Australia for esophageal is adenocarcinoma. Okay, clear? So this is the two very important info. Now, you know what I recommend? Sometimes what you can do, like see, we all have some sort of sticky notes like this. Have you ever used it for any study purposes or something like that? I'm sure you do. So things here, like this kind of sticky notes, you can write down things later. by making fresh or any important, like as I just now mentioned, like number one worldwide is squamous, then most MCC in Australia, which is um, adeno. So any important informations like that, you know, extra which is in the classes, or you think it's important for the exam or the solving people, like you can make sticky notes like this, and you can add them with a scotch tape or anything else with your book. Actually, many people do that. Many people put this thing in the wall, whatever it is, whatever the way, make it happen. Have you seen many people posting in our Shahriar's MC guideline group? Their walls are full with, a lot of, sticky notes and this, that. So that much hard work they have done, not only in the wall, but it's full inside the books actually. So that amount of study they have done, I'm sure you will do also the same and you will get through it. Okay, summary, its prognosis is bad. So what is the ideal? Ideally, what you can do. So if grades are permitted, like stage one, stage two, up to some cases, up to stage 3A. Okay, most cancer cases, stage one and two, you can do surgery. It still depends on the location. And stage 3A, condition applied actually. Stage 3B, 4A, 4B, you can't operate. Is that clear, everyone? Usually, I'm telling usually the word is still a lot of aspects, health, lung function, heart function, many things. Stages, I'm talking about the stages and the gradings, these things like stage 4A, 4B, and stage 3B can't operate. All good? Okay. So you see, weight loss, dysphagia, suspect esophageal cancer, achalasia, these things are done. These things are drug. Now, drug can also lead to esophagitis, that is the NSAIDs or any drug like doxycycline or any dangerous antibiotic can lead to esophagitis as well. Now, have you ever seen someone is coming and tell, doctor, I think something is in my throat, maybe a fish bone. Did you hear things like that? And your ENT professor wrote a headline, Globus. Okay. Have you seen this thing? It's like this thing, like a Globus. I mean, when they feel it's like a kind of fake, actually, So the Globus is the Globus. Sensation being choked up or sense, oh, something is in here. It's mostly psychological feeling. Yes. I hope that's clear to the dear doctors. We're still in the esophageal cases. We're at 453 page, please, Sorena. Okay. So since you learned about dysphagia, another thing is odynophagia, painful swallowing actually. Previous one, difficulty in swallowing. This one is pain during swallowing actually. So again, GERD, esophagitis, and some other conditions can be there. Anyways, that's not very important. Important is a eosinophilic esophagitis. Eosinophilic esophagitis. Now, here you go. I mean, I hope so it is visible. Adult with a long history of dysphagia and more for certain types of food. Okay, let me see if I can add that one. Anyways, adult with a long history of dysphagia, that means previous history of dysphagia, more at certain type of food. So, okay, so with particular type of food, they have issues and long history of asthma, endoscopy revealing multiple constrictions. So please write down a keyword, endoscopy showing multiple constriction. Um, some particular type of food they have problem, and there can be family history of like things actually, family history of allergies, family history of other thing. Now, one thing, you know, allergies are like brothers. Allergy, bhai, bhai. Did I mention something like that in previous class? Like if there is one sort of allergy in the family, there's another type. You probably have seen this thing in your family as well. If, how many of you are allergic to something? I mean, say I'm allergic to kind of, yeah, it can be food, it can be, I think I do have dust allergy a little bit, I think. So do many, I think. A little bit dust allergies are there. Sometimes if I eat too much chili, which I don't eat nowadays, I start getting some flushing. I don't know why. Okay. Some people can be with perfume, beef, prawn, many things actually. Okay, so here the finding is actually like multiple constrictions, not really stricture, multiple constriction on endoscopy. Okay, great. Okay, so here is the thing. Please highlight there can be dysphagia, there can be other allergy conditions like asthma or any other allergies. And if you test them, there will be IgE level elevated. Now, since it's allergic, many other allergy condition we give antihistamine, but if it's a prominent allergic condition, only giving antihistamine like fexofenadine may not enough. Then what do you give in that case? Or as a step up, what do you give? Answer, in that case, we go with the steroid. So eosinophilic esophagitis cases, because it's a bit extreme allergic condition, because it's a bit extreme or at least moderate allergic condition, but the condition can be also severe, you need to give steroid actually. Okay, so here is the thing. So here, so steroids are given. Now here is the thing. Initial test is barium, but confirmatory is endoscopy. Upper GIT endoscopy showing multiple constrictions. This is for the eosinophilic esophagitis. Next day, I will show you a recall question now how it is tested. Is it clear so far, everyone? Eosinophilic esophagitis, everyone? Eosinophilic. We do have a note in the note section as well. I mean, you can check, I think, but we don't need to go into that one. I think we already did it well. Not a very difficult one. Still, let me show it to you one time. So it's a food related strong link with a certain food affects the children and adults associated with allergies like HIV, this that IgE level and gastroendoscopy shows this that symptom improves instead of removing the triggering food. So initially as a management, if they give you steroid or they give you uh, stop the offending agent, stop the offending food, which one do you think is number one priority? Confirmatory is endoscopy, guys. So initially stopping that particular kind of food, stopping drugs, stopping food, these are number one. Unless it's a life-threatening that like wheeze, patient is struggling with the breathlessness, which is a different, then you need to calm down the patient first actually. But if it's like a moderate situation are under control, in that case, stop the offending agent always. This is stop the offending agent. Many times it will be tested in MC, not only for this disease, but many other diseases. Remember last year there was a recall. Stop the offending drug in welder strong. Do you remember that, guys? This is one of the pattern of uh, asking. One of the pattern of asking like stop that offending drug in welder strong actually. All right. Here, stop the offending food. Right. So acute attack like I am Buscopan following yeah, this that investigation has to be very influential. Yes. Is it clear, everyone? So far, is it clear? I hope it is. Fantastic. No worries. This situation we take a little bit time, and we are taking you back to our original earlier page where we started with discussing with some of the esophageal conditions. Here we go, GIT theory. So GERD, Achalasia, Barrett's, esophagitis, interrelated esophageal cancers, esophagitis, eosinophilic esophagitis as well. Actually, stricture is moreover related to dysphagia to solid, and there can be history like CERD and things like that. Last two of this particular situation, including the ZES, like Zollinger-Ellison syndrome. Another one probably you can add here is a, but that's more related to stomach, right? Like let's not put it here actually. Okay, so the last two is Boer Habs and the Mallory West. Now, starting with a quick question, which one do you think is more dangerous? Is Boer Habs more dangerous, or is Mallory West is more dangerous? Okay, let's find it out. Just again. Okay, this is more like the Boer Habs, guys. So Boer Habs. So you can see this is the situation in Boer Habs. Now, one of them particular, yeah, one of them in particular, actually, as you can see, guys, relevant things are supposed to be there, like, but not 100% things. I'm not sure. Like sometimes one to extra slide I can show you because sometimes during the class we also take preparation. So one two slides may not be there, so that's okay. But the major thing is that it should be important is to relax because if something is notifiable, I'll ask you to take a screenshot. Otherwise, most things are already there. Okay, now coming back to that one, the warehouse in warehouse, why we are telling is the more important situation than even though malady is it's the dangerous because in warehouse there is a tearing in the esophagus area. So if there is a tearing in the esophagus, that can be extremely dangerous. And also there will be a shifting at some point. So that can lead to lung symptom even. So you can see the X-ray demonstrating a pneumothorax by the Boer halves, the pressure, yeah, indicating another sign they're almost collapsing because of this Boer halves. So much pressure and compressing the lung into another part. Okay, so this situation can lead to even dangerous pneumothorax. So summary again, in between Mallory West and Boer halves, which one is more dangerous? Uh, Boer halves is perhaps more dangerous. Okay, because it's tear. I mean, all tear. And malarious waste is tear inside mostly, and that will lead you to bleeding, bleeding, vomiting. So tearing inside, another one tearing outside mainly, but tearing inside outside. Everything is teared up. Okay, everything is teared up. Okay, so this is how a situation thinks. I mean, this is how a question that is given. Some cases, a 40-year man after a conference meal. Imagine the days. I mean, when you guys were intern, maybe some of you are already intern. Do you like used to eat a lot during that particular time? I mean, so many free food and this, that. I think boys will say yes. College canteens, lot of drug companies, seminars, and this, that. Okay. Anyways, me and my friends used to eat like a marriage ceremony or whatever. Imagine marriage ceremonies. Imagine like their marriage ceremony. So when we go out, I mean, if there's the best possible foods out there, like biryanis or anything, uh, maybe maybe not everyone is a food lover, but at certain point, everyone was eating a little bit more than current days actually. Okay. A 40-year man after a conference meeting now is feeling forced vomiting, suddenly pain in the retrosternum. Maybe looks like heart attack even. Has got ischemic heart attack before, so it's of course they'll be thinking it's another attack. After resuscitation, the most appropriate step in this case. Maybe initial resuscitation I've done checking the ECGs and probably confirms not a heart attack. Then after that, what you will think? Answer is that you will go for a lateral chest X-ray. Why? Why chest X-ray? To rule out Boerhaave. So here is a little management of Boerhaave also given. Um, IV fluid intravenous, an antibiotic because there is tearing is happening, so the food area is mixing with the other part. Nothing per oral because you need to repair this part. Admission to ICU, really serious condition. Surgical repair, is it required? Yes. Risk of death even after surgery 25. So it's a very dangerous situation. Very, very. As I said, esophageal areas are extreme dangerous. Now, last but not the least, this one I think you should take a screenshot because this one probably does not maybe available. This particular picture, I want you to take a screenshot. This is a major, actually differentiating. Okay, so you can later ask for this chart in the inquiry zone. I can again upload this one there, or you can take a screenshot now. Especially differentiating table actually. Now, differentiating, you can see the situation: forceful vomiting, like it's a forceful retching, and you see life threatening is not life threatening. This is a major differentiating point. Full thickness rupture, this is a keyword. Okay, results in bleeding may cause bleeding, but it can lead to certainly respiratory symptom, breathing difficulties, because remember it's compressing the lung, collapsing of the lung on another side. Often managed conservatively because it's just bleeding, so you can try some conservative initially. If not, then surgery things. Immediate surgical intervention for Boerhaave because it is much dangerous situation. Much dangerous situation. Okay, good question, very good question. Most cases, how we can put a lot of pressure on esophagus. I mean, already a little earlier I mentioned, no, not vomiting. I mean, where you have gone, eating a lot in a particular day, like buffet lunch actually. Remember your buffet lunch days, as much as I have seen a friend even taking laxative with him actually, so that he can eat more actually in a buffet lunch day actually. Crazy. Seminar, yeah, seminar food. Okay. All right. Binge eating, and also you can add binge drinking because a lot of people drink a lot in the parties and they also eat and drink at the same time. So they're pressurizing a lot here, esophagus. Yes. So medical emergency, rarely an emergency. So everyone, are we clear with all the esophageal things? Are we clear with all the esophageal things? Yes. Okay. So summary again, every esophageal condition, GERD, heartburn is one of the key feature. Achalasia, no heartburn, and dysphagia to the liquid food. Both of them, investigation, management we learned. Then Barrett's esophagus, it's a pre-malignant condition, and 2 yearly follow-up is the key. And you need to follow up again every 2 yearly by endoscopy. Then esophagitis because of any condition like GERD or uh, already having ulcer or any issues, you can again have esophagitis. Esophageal cancer, we learned upper two-third, lower one-third, squamous, adeno most common in Australia. And of course, you need surgery if applicable, otherwise chemo and all these things. Malarious Boerhaave, just now we learned. Eosinophilic esophagitis, there is family history, other allergies history, IgE level elevated history, and of course, you do endoscopy Boerhaave, I think not available in John Mukta. And in eosinophilic esophagitis, at the same time, there will be you need to give the steroid at some point, fluorinated steroid. Okay, so this is important, and IgE level will be elevated, and there will be other allergy histories in the family because it's an allergic condition actually. All right, great. Okay, 452. Let's see, anything is there. I think we are almost over here. In new book, this thing has been added. So to please highlight is this possibility of candida treated with nystatin. Just highlight it, nice to know. And herpes cases as included, just nice to know. Great. Okay. So guys, we think we are done with the esophageal things. Are you clear with it? Yeah, all good. Please give a thumbs up. Are we clear? Are we clear with all these things? So that we can go for the next one. All right. We'll take a break now. So after the esophageal thing, we'll come to the stomach. It has less diseases than the, uh, you know, compared to the esophageal. Esophageal, more things comes in the exam. We're going for a break now. When you'll come back, peptic ulcer disease, non-ulcer dyspepsia, stomach cancer, stomach-related bleeding, and these things we will go forward. Thank you so much. See you all after the break. So we're going for a 10 to 12-minute break here. Thank you. All right, everyone, let's get started. Thank you. Okay, yeah, great. Yes, we are back. So after the esophageal thing, which we just now finished, we are going to have the stomach related thing. Are you guys ready? Mhm. Great. Let's go and start this session actually. All right. For this section, I'd like or request you to open the this particular section of peptic ulcer disease. Okay. Again, in the same way, we like to differentiate few things um, from the stomach. Can we recollect some of the important diseases related to stomach and can be also popular in the exam? Starting with, if you see, like this, so it can be peptic ulcer disease, very popular in the exam. All right. What else? Okay. Anything related to ulcer, like non-ulcer dyspepsia, that's also important. What are the other things we're looking forward? If there is a mass or like a growth, so like a cancer, there can be bleedings due to any reason, which is known as the upper GIT bleeding. Some situations like bleedings due to like a gastritis, drug induced, esophageals, or any stomach bleed. All right. Then comes some of the situations in these particular areas, like it can lead to obstruction. Like what is that? GOO, gastric outlet obstruction. Very, very popular in the exam. Gastric outlet obstruction. Okay. Anything else you like to add? Okay. We can start with this. That's okay. Um, yeah, Zollinger-Ellison syndrome, of course. We mentioned earlier, but we'll finish it here actually. Okay. Immediately after peptic ulcer, we'll go with the Zollinger-Ellison syndrome actually. Okay. Now, starting with the peptic ulcer disease, in starting with peptic ulcer, mainly we know duodenal ulcer and gastric ulcer, right? Mainly we know about uh, gastric ulcer, and another one would be duodenal ulcer. These two. Now, one of them we call like both of these situations related to like say clinical feature. What are the clinical feature? Like starting with a abdominal pain. To be more specific, epigastric pain. We're at page number 446. Please check, like, always page numbers are given here actually. Okay. So here is the thing, like clinical feature. So upper abdominal pain mainly. So mostly epigastric tenderness or duodenal point tenderness. These are the important thing. Both of these cases kind of same thing, but uh, still there is a differentiation with the food actually, relation with the food. Now one of them is known as hunger pain. Repeat, one of them is known as the hunger pain. Which one is it? Is the duodenal ulcer, often known as the hunger pain. You guys looks very less responsive, so I'll be going on faster, understanding that you guys are understanding everything. Okay, so it's like a hunger pain, and in gastric ulcer, when you take food, in that case, you will feel more pain in case of gastric ulcer actually. Both of these cases, weight loss can be a feature, but more evident in which cases? Because when you took food and you start feeling pain, so in cases of gastric ulcer, you start losing weight. In case of gastric ulcer, you started losing weight actually. Okay. Another important point is actually about the perforation, and the bleeding. 2 points. Both can happen as a complication of ulcer, but uh, perforation is more common. Perforation is more common in case of duodenal ulcer, whereas bleeding is more common in gastric ulcer. But understand both of the things can happen in both cases actually. So these are the some of the differentiating point. I repeat, these are some of the differentiating point. I mean, just to know the basics, they will not ask you the differentiating point, honestly. They'll come up with the scenarios like, is it a peptic ulcer disease, or it's like a heart problem, or like a pancreatic problem. They'll give you scenarios in main exam. You'll need to either make a diagnosis or make an investigation or a follow-up actually. Okay. Coming to this one, peptic ulcer disease, here's some risk factors given, including H. pylori. Earlier we mentioned H. pylori associated disease. Peptic ulcer disease is one of them. So our mainstay would be always related to H. pylori, eradication of H. pylori. This is very, very important. Some drug can lead to this situation, including NSAIDs and corticosteroid. Okay. So this particular thing, can happen definitely. So burning epigastric pain, which can be related to the meal. It has very strong relation of the meal, especially duodenal ulcer, hunger pain. When you are in the empty stomach, you feel pain, and when you eat, you have more pain in case of gastric ulcer actually. Right. So these are some of the important thing. These are some of the important thing. Endoscopy, investigation of choice. In these cases, investigation of choice. Secondly, barium studies, and lastly, H. pylori test. Actually, urea breath test is another important. Urea breath test. Now you can highlight this particular line. Urea breath test. Actually, now urea breath test, is it only diagnostic or is it also used for the follow-up? It's a handbook question actually. So you can also write near to this as a HB as a handbook question. So in the handbook question, it was there. The patient was diagnosed with H. pylori, urea breath test done, urea breath test done, and H. pylori positive. Now you give triple therapy. You must be knowing for peptic ulcer, H. pylori positive, we give triple therapy, triple antibiotics. How to follow up in that case? Would you like to go for endoscopy, or would you prefer the urea breath test in that case? In that case, we prefer urea breath test actually. So it's not only for diagnosis, but also to see the prognosis and the follow-up. I hope that's clear too. So normally starting with endoscopy, provision of barium, and also H. pylori test, particularly urea breath test. Urea breath test actually. Now, ulcer can lead to complication, already mentioned, perforation, bleeding. Please write near to this one, perforation more for the duodenal, and uh, gastric, more related to this bleeding thing actually. Right. So there are other situations like gastric outlet obstruction, then pyloric stenosis. These are also some of the very important thing. Yes, anemia, cancer, stenosis, all these things can happen. All right. Okay. In this case, if we see if H. pylori positive, okay, so eradication therapy is needed. To confirm the eradication with urea breath test. So this is the line you need to highlight. If H. pylori negative, treat with full doses of PPI actually. For example, patient will come with ulcer with lot of epigastric pain, relation with the meal. Already when you're taking meal, maybe more pain or whatever the way has relation with this. So it means it's a classic peptic ulcer disease and it should be treated with PPI. But if H. pylori negative, no need of triple therapy. If H. pylori positive, you need triple therapy in that case. You can also increase the dose of the PPI if needed. Okay. So H. pylori eradication therapy, I mentioned how to follow up. Again, follow up with the urea breath test. Okay, now this is the triple therapy. This is the triple therapy, as you can see. This is also the triple therapy. Now, there is another thing would be given. The patient is H. pylori positive because of peptic ulcer disease. You give triple therapy, and triple therapy is not working. I repeat, this triple therapy, you can bracket this thing and write why triple therapy not working. What can be the reason? Some cases. Now, it can be reason. It's a resistant. Now, which one of the following drug has more chances of getting resistant? And this one is a metronidazole. So metronidazole resistance, it can be a bigger problem. Metronidazole resistance can be bigger problem. Also, I want you to highlight this one. Maybe in the next edition in future, there will be more updates to this. Resistant metronidazole is common, and nowadays is clarithromycin is also increasing actually. Okay, so alternative to metronidazole can be clarithromycin, but nowadays we can see clarithromycin resistance is also increasing. Another thing, children can also have H. pylori. So PPI, amoxicillin, and clarithromycin. Children with confirmed H. pylori. Okay. So in NSAIDs cases, as you can see, if there is a causative agent, like because of peptic ulcer, someone is taking it, stop that offending agent. You must be knowing NSAIDs blocks the prostaglandin thing, prostaglandin, which is quite important for our GI lining. Okay. So this is important. Are we clear about the peptic ulcer? We learned about the differentiating thing. We learned about, okay, you can check the risk factors. It's easy. It can be because of H. pylori. Main stem, you need to eradicate this H. pylori by triple therapy. How we made a diagnosis by doing some of the simple things like endoscopy, then we can do barium, and we can do H. pylori particular test, which is known as urea blood test. Then we give that particular patient H. pylori eradication therapy. These are the drug names of H. pylori eradication therapy. And we follow up with urea breath test. Repeat, we follow up again with a urea breath test. All right. Is it clear to everyone so far? Peptic ulcer. This is the maximum question can be asked actually. Quadruple therapy, it's given. You can just read it actually. Yeah. I mean, if you need more, I mean, from switch triple therapy, if situation demands to step up, then you can go for quadruple therapy as well. Clear? Great. Now coming back, there's another five-star topic is a bleeding peptic ulcer. So the patient presents with, of course, abdominal pain, epigastric pain, all this thing, previous history as well about this pain thing. It can be so severe, by the way, guys. Okay, so injection adrenaline and injection omeprazole in that case. Okay, so you can see bleeding peptic ulcer cases, not only IV PPI, but also IV adrenaline. Mainstay is the injection adrenaline. Okay, there's another option for heater probe, but I haven't seen this one coming in exam, but I have seen injection adrenaline coming into the exam. Is it clear, everyone? So basic peptic ulcer disease and bleeding peptic ulcer, the management would be a little different. So please highlight that line, that injection adrenaline, that is a different management because it's a bleeding peptic ulcer. Which one is an emergency? Bleeding peptic ulcer or the regular peptic ulcer? Bleeding peptic ulcer is a very big emergency in some cases. Triple therapy things are 5-star. Why it gets resistant, that's another 5-star question actually. Some cases they will give you a disease like someone has Cushing syndrome and the person develop peptic ulcer disease. Why Cushing syndrome person develop peptic ulcer disease? Any idea? Any guesses? Because the stress hormone, the cortisol hormone level is increased. Cortisol hormone level is increased. So automatically that person gets for possible peptic ulcer disease. Some people using NSAIDs for their pain. They can also develop peptic ulcer disease. This type of question we have also seen coming in the exam. As a nice to know, you can write this thing like H. pylori associated diseases, which we already discussed previously, right? H. pylori associated diseases. So any cases where H. pylori positive, you can consider this triple therapy things. All good, guys? So far clear about the peptic ulcer disease? The differentiation, if you just Google it, gastric ulcer and duodenal ulcer, you will find so many charts in the Google. I think it's the MBBS topic. I think if you all remember duodenal ulcer versus gastric ulcer. So I'm not getting into that chart. I just verbally discussed actually. All right. Next coming is a stomach cancer. It's a easy peasy, but they will come up with another new pattern of question. Please listen carefully this part because this is another pattern of question sometimes they ask. They'll give you a scenario, a person who is 62 year, presents with weight loss, dyspepsia, and also nowadays looking pale. Pale, why? Because probably iron deficiency, anemia. Okay, and maybe bowel habit has changed a little bit actually. So What do you think? What can be the diagnosis actually? And not only weight loss, sometimes feeling a little bit abdominal pain actually. So your possible diagnosis is maybe a stomach cancer. That's a possibility along with many other differentials actually. Now, the question what they will ask you, which of the following is the most prominent clinical feature? I repeat, which of the following is the most prominent clinical feature for stomach cancer? Okay, the answer is a weight loss. So they will give you, you'll be confused between abdominal pain and weight loss. Weight loss is the most prominent feature. All good. Can H. pylori plays a role here? Yes. H. pylori can play some role here. You can highlight this line. H. pylori is. And also, I want you to highlight this dyspepsia, unresponsiveness to treatment. Normally, if you treat the dyspepsia, I mean, if you some drug, PPI, this, that given, it is supposed to be fine. But if it's days after days, this dyspepsia just increasing, and even increasing the dose is not helping, it means there can be underlying some pathology. And any sign of anemia, any sort of iron deficiency anemia, it's a very high possibility. Okay. So age, blood group A, smoker, even a diet. Can you tell me, like country-wise, which country do you think is a bit more um, prone to develop stomach cancer? If I'm not, I mean, um, mistaking, I think if you remember Japan, because like more smoky food, raw food, and all these things. So yeah, and I think personally, like uh, our country, like Bangladesh, we don't have that kind of studies, perhaps, you know. Anyways, but probably the amount type of food we are eating, but the colon cancer chances would be more higher in our country, like spicy food, junk food, fried food. Remember one thing, nowhere those deep fried, always try avoid the deep fried food. Even when you go to a restaurant, there's always option like salad, cashew nut salad, and any other things. So somehow we all love to go to restaurants. So just try one adjustment, try about the deep fried food actually. Biryani and into the kind of not bad into that category because the process of the meat thus goes under a lot of oil, this, that. Yeah. I think not only in Bangladesh, I think a lot friends of ours from Pakistan is also loving biryani, I think. So as a lot of Indian doctor and yeah. Um, I also found I've been to Sri Lanka. Their foods are also quite, I mean, oily, I would say, at the same time. So it's kind of like we all are connected to oil in some way. I mean, we don't have oil uh, reservation, but we like to eat oils, actually, interesting sarcastic joke. And rather than, if you see the Middle East countries, they have a lot of, you know, oil and those things as a reservation, but they eat less oily some cases, more like kebab and this, that. Anyways, actually, our food, I think, is kind of more oily. Yes. Okay. Make sure, you can eat biryani, but make sure it's not a day-to-day food, you know. That's the thing. All right. Okay. Can I say one thing that if you see any lymph node enlarged in the left supraclavicular area, it may also indicate a stomach cancer. It's often known as the Varco's triad, if you see. Possible? Yes. Oh, thank you so much. So from which country I'm getting this biryani? Okay, someone is. Oh, no, very nice. Okay. Maybe someday I will come to it. No, it's inshallah. All right. And vice versa, same invitation. All right, great. Now coming back to this one, malaise, anorexia, dyspepsia, and weight loss. Again, Tuck's triad, John Moore Tuck's triad. Again, it can be. So please always check the keynote like a weight loss, then anemia, then weakness. Often very common symptom can be also weakness. Yeah, dyspepsia, change in the bowel habit. These are also very, very important actually. Some cases palpable mass, only 20% cases. Very rare. Right. So that's some from the stomach thing and from let's come back here. Okay, so ulcer, the mass, the bleeding peptic ulcer, basically we're talking about. And another one is the GOO, gastric outlet obstruction. Mainly, you know, gastric outlet obstruction mainly is our surgical topic. But since you asked so, what can be some of the clinical feature of gastric outlet obstruction? Surely it's a vomiting because outlet is obstructed. Outlet has been obstructed. Okay, so it will lead to like a vomiting tendency, and vomiting is intermittent, usually occurs within 1 hour of meal. Usually it will occur within 1 hour of meal. All right. Another popular thing we will see in the pediatric cases like a pyloric stenosis. So GERD versus pyloric stenosis will be a very popular question in pediatrics. In pyloric stenosis, there will be projectile vomiting and there will be a palpable abdominal mass. Okay, which is not present usually in GERD, which we will see in the pediatric case actually, and gastric outlet obstruction we'll see in surgery. So nausea, vomiting are cardinal symptom, and they will give you a picture of a barium. They'll give you a picture of a barium actually. Okay, so barium, you'll very clearly see the obstruction. I will show that one in the. Or if you don't get time, there is a very nice website. Let me tell you the name of that one. Its name is actually Made Bullets actually. So in little advanced study, if you want to do Made Bullet, a little advanced study if you want to do, you can just type that name and they will show you some particular diseases, and you can type gastric outlet obstruction, you'll find it actually. Okay, otherwise, I mean, of course, in the surgery I will go through the more details about gastric outlet obstruction, but for now, nausea, vomiting are the features. Intermittent vomiting, because 1 hour after meal this is happening actually. But if pyloric stenosis, is it 1 hour after meal or immediately after meal, guys? If pyloric stenosis, will it be 1 hour after meal or immediately after meal? Answer, it will be immediately after meal. There will be vomiting and projectile vomiting. Okay, that's a differentiating point. So going to the stomach, I think one thing left, that is it also has our note in the note section, but still let's go with it. Excellent. Okay, this is how it's given in the note section. And if you go through the SMA note, okay. Okay, before going into this one, let's check out the what books has to say. By the way, Zollinger-Ellison syndrome is not given in John Murtagh in that proper way. Okay, so that's why you have to take help from some of the other slides. Zollinger-Ellison syndrome already given in our notes actually. Okay, now let's come in and focus. Now, starting with that one, is this condition is like other peptic ulcers? A quick question: are the symptoms are like the other peptic ulcers, like epigastric pain? It has some relation with the meal. Um, is it this? I mean, initial some of the symptoms are the same or not? Answer: it is kind of the same. Epigastric pain, then heartburn, okay, ulcerations, everything. But the question is, what's the difference then? Is it a one ulcer or is that a multiple ulcer? That is the question. So there is multiple ulcer. Multiple ulcer. Now, if you have multiple ulcer, The severity of pain would be like other peptic ulcer, or will it be even more in this case? Answer, it will be even more in this case. Okay. This situation is also considered as a cancer. Looks weird, right? Zollinger-Ellison syndrome. Is that also considered as a cancer? True or false? Answer, true. Which type of cancer it is considered? Gastrinoma. Gastrinoma. Now, let me highlight something for you. If this is the particular, as you can see, if this there is a something like gastrinoma, as a result, gastrin is produced. More gastrin is produced. Gastrin comes here, works on the parietal cell. Do you remember this term, parietal cell, guys? I know it's like been long. So stimulate the parietal cell and helps releasing what? Helps releasing HCl. So more gastrin, enormous gastrin is produced normally in this case. So more gastrin produced, more stimulation of parietal cell, more and more HCl is produced. Is that a good news now for your stomach? No, because of so much HCl, it start affecting here, 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 everywhere, and there will be multiple ulcer. Now, what is the function of gastrin? If you remember, motility. Am I right? So one is affecting parietal cell and also increasing the motility. So it produces the HCl and secretory acid, yes, and helps in also gastrin. Uh, this is a gastrin, it's a motility hormone as well. It has a name. So it helps in the stomach peristalsis or this movement. Now, if when there's too much gastrin produced, too much HCl will be produced as well. Now, can we say if there's too much HCl, the food will pass more quickly and it will lead to diarrhea? Can you correlate now? So can you say motility increase? Motility will increase, and as a result, there will be diarrhea. Now, coming back to this particular part. So Zollinger-Ellison syndrome, increased gastrin, more acid, and peptic ulcer disease and diarrhea. These are common, and there is multiple syndrome, multiple ulcers because of more HCl, more area covered. And extra thing to remember, every disease has some association. This is something very important pattern in AMC. Very important, guys. Like you need to know important association. I mean, every disease can has association with a lot of things, but for AMC, you need to know some important association. Zollinger-Ellison syndrome can be associated with main one syndrome, which I will teach you in the end of time. I mean, if you have a tumor in one part, you can have tumor in the some of the other parts actually. So main one syndrome, it can be associated with main one syndrome. Please do remember this thing. So suspicious Zollinger-Ellison multiple ulcer ulcer does not work to the therapy. See, typical peptic ulcer works with PPI. This one does not work with PPI. Key line. Okay, this one associated with diarrhea. This one associated with multiple ulcer. Okay, peptic ulcer disease. Is this we I mean with H pylori? Is this situation with H pylori or without H pylori? Zollinger-Ellison. I think usually without H pylori. I think yeah. Usually without H. pylori, but can be. I mean, some cases overlapping because already multiple ulcers. So you can see in the lab, gastrin level, bowel ratio, and you need to do endoscopy. Endoscopy will show as a confirmatory of multiple ulcers actually. Same thing, they mention high gastrin level, gastrinoma of an institute of diarrhea understood. Hypercalcemia can be a feature because main one association associated with hypercalcemia. So gastrinoma is confirmed, most important to exclude metastasis. Uh, CT and MRI of the abdomen have poor sensitivity, but can be done. Yeah. So local disease can be removed surgically. Metastatic disease are not resectable actually. So support as a support PPI can be given. Okay, I'm speaking about this thing. Yeah. All right. This one will help you even more. This is already given in the note, in our note section. So it's a little bit like cartoon, gastrin, more HCl, ac- working more on the parietal cell. Now more HCl and more ulcers. So those things are here. Increased gastrin, increased ulcer, increased diarrhea. Four main one associations. So treatment, chemo, PPI. We'll try surgery, but most cases surgery may not be possible. And the pathophysiology why this ulcer or many ulcer is because of gastrin. Okay. Therapy of choice for Zollinger-Ellison syndrome. It is the PPI. Proton pump inhibitor is the choice. All right. So is it clear, everyone, from the peptic ulcer disease, even though it's not given in John Martha, but we managed to see it from the SMA note. Okay. So that's why our notes are important so that you can go through all these things actually. Okay, great. Okay, slowly we are proceeding and we are proceeding after this one into some of the stomach, after stomach, the intestinal, some of the intestinal areas. All right. Now, some of the more intestinal conditions like, say diarrhea, malabsorption, celiac disease, traveler's diarrhea, and IBD, very important here, inflammatory bowel disease. As we said, the intestinal obstruction is mostly part of our um, surgery, but we'll try to give you a little touch on that one as well, so that during medicine and also in surgery, you'll have like double ideas actually. Okay, let's get started with the thing diarrhea. This chapter is more like a nice to know. Okay, this is page number 410. By the way, here my page number is always given. So 410 is the page number. So diarrhea related, we all learned in MBBS level, acute diarrhea till like the um, acute diarrhea and the chronic diarrhea. These are some of the things. Uh, then watery diarrhea, bloody diarrhea. These are some of the other things. So you see, watery diarrhea, bloody diarrhea, chronic watery diarrhea, stoturia. In general, these things are given. These are for the general basics. Now, the more important thing for you to know that is it a acute diarrhea or is that a chronic diarrhea actually? Or is that a watery diarrhea or is that a bloody diarrhea? So you really, really need to differentiate. So just take these parts is already given. And some of them can lead to gastroenteritis. There will be abdominal pain, fever, and diarrhea. Abdominal pain, fever, diarrhea. Adult cases, also some of the child's cases as well. As you can see, rotavirus can be very dangerous. I'm going a little faster because diarrhea related things most people know well. Some of the red flags for diarrhea also can happen if diarrhea associated with blood or very high fever or diarrhea associated with weight loss. Right. There is a one question. This is a handbook question you can write as a HB 412 page that a drug which is used in gout, that is the colchicine, uh, can lead to diarrhea actually. But many other drugs can also lead to diarrhea at the same time. But this is a handbook question. So I thought to just highlight this one a little bit for you. Okay. Here also it is given, like as you can see, just highlight a little bit. These two conditions, staph and salmonella and bacillus, uh, can cause diarrhea even in very short time, actually, like within few hours, because of staph aureus and the salmonella. You can have the diarrhea and the vomiting, like basically gastroenteritis. Very high possibility. Nothing, so many things are given. A sign of dehydration, please, nice to know for you. We all learned it in MBBS. I'm not getting there. What are some of the sign of, you know, dehydration? Have a look on that one, actually. All right. Next important thing is coming is the malabsorption. Do you guys need 1 minute or 2 minute break here before I break down the malabsorption and inflammatory bowel disease? And coming up is the IBS, actually, these things. Celiac is also there in between. Right. Okay, I need 2 3 minutes break, guys. Yeah, in order to have little voice recovery, I mean, that's important. Because I've been talking continuously for more than 2 hours, I guess. So I'm just giving a little 3 minute voice rest. Thank you. Okay, so we are doing some of the intestinal thing, and followed by there is this diarrhea thing came up and the malabsorption thing came up. For diarrhea, please read about the acute and chronic and watery and bloody. Read their causes and also read about the gastroenteritis and relevant antibiotics of all these particulars. So I think the relevant antibiotics are given at the end. Let me just check out one time. Okay. Before coming into malabsorption and the very important celiac. Yeah. In 420 page, please take the assessment of dehydration. I'm not getting into there. It's more of a pediatric topic. Plus, it's a nice to know as like a MBBS topic. Please have a look on that one. I think anyone can read it. And um, here is the thing about the traveler's diarrhea. So E. coli can be a culprit while traveling to the overseas countries. So traveler's diarrhea, we know about it. And here we go. At page number 400 and 22, you can see this is I was talking about the earlier sign of diarrhea or sign of dehydration and acute diarrhea, chronic diarrhea, and at the same time bloody diarrhea, non-bloody diarrhea, and the managements of various diarrhea. Any diarrhea cases, what is the first line of management? Anyone? Any diarrhea cases, what is the first line of management? Is it antibiotic or is it the dehydration? Answer: maintenance of dehydration, giving IV fluids is the first priority. Then, of course, we'll look into giving appropriate antibiotic. If it's a gastroenteritis, severe diarrhea, vomiting, not only you will give the fluid, you need also give antibiotic if vomiting, anti-vomiting, antiemetic medications can be given. Depends on the situation. Now we are coming into the this causative microorganisms, treatment of the antimicrobial. As we mentioned, antimicrobial microorganism related question does come. So these drugs are also important. There's a very high chance from this particular 2-3 pages, you will get one particular question actually. Starting with this one, like Shigella, it can leads to diarrhea, right? So often a cause of bloody diarrhea, please mark the antibiotic. Here I cannot help you because you have to memorize this. But Giardia. Now, Giardia, is this a cause of acute diarrhea or chronic diarrhea? Shigella is more like that acute diarrhea, but in Giardia is also it can lead to steatorrhea, or it can you can say chronic diarrhea. Actually, the Giardia is 5-star for our AMC exam. Often you can write to the word near to Giardia is a aboriginal, I mean their local community, aboriginal, and foul, smelly stool, badminton shaped parasite. These are some of the keyword badminton shaped parasites actually, and malabsorption, of course, actually, and often there will be fat along with the stool. That's why steatorrhea. It often float in the toilet. Now, how to treat that condition there? So they will give you a scenario. You can search with this keyword in Shahriar's MC guideline. You will find Giardia related questions. So metronidazole is your mainstay. I hope that's clear. Again, salmonella, often cause of acute diarrhea, very short incubation. You can write this thing near to this. Very short IP means intubation period. So Bacillus and Salmonella has very short intubation period along with the Staph aureus actually. So Salmonella cases, it is ciprofloxacin. Salmonella cases, ciprofloxacin. Now, do you remember there is a mnemonic um, alongside Salmonella, Salmonella typhi Salmonella, if it is the causative, like how to investigate. There's a mnemonic called BASU. And anyone remember BASU? Familiar with this, the BASU thing? I'm sure you do. So, Salmonella investigation is a BASU. It's actually week wise. First week, second week, third week, fourth week. These are weeks actually. So in this case, blood culture, agglutination test, or you can say that Whittle test. This one is a stool culture. Last one is a urine culture. So it's more like the week wise actually. Salmonella can be a individual outbreak or can be a community outbreak. In case of community outbreak, we go for stool culture. This is a AMC exam question. Some of the community outbreak cases, we go for the stool culture sampling. Okay. 1, 2, 3, 4. Okay. Coming to that one, ciprofloxacin is the mainstay. Ciprofloxacin, we all know that. And also you can give ceftriaxone at the same time. Campylobacter jejuni, azithromycin. Another thing. Amoebiasis, where you have learned about amoebiasis in MBBS. I'm sure we all did learn about the amoebiasis. It will be somewhere taught somewhere in some of the surgical one of the class. So this is related to the liver abscess, if you remember. Some of the liver related cases, amoebic liver abscess, So metronidazole is the mainstay. Okay. This one you can highlight as a nice to know. Again, blastocystic metro. Also, typhoid fever, azithromycin for 7 days. Cholera, now it is very less, but again, It can lead to very serious diarrhea. Rehydration is the key, and again, azithromycin or ciprofloxacin. Okay. So again, recapitulating, guys. This is page number 422, antimicrobial treatment for diarrhea, diarrhea sign symptom, uh, sign of dehydration, the immediate previous page. And you will also learn the causes of watery diarrhea, causes of bloody diarrhea. If you don't find in the book, please do ask me in the inquiry zone later after the class. Doctor, please show us chart of the watery diarrhea causes, bloody diarrhea causes. I'll supply that in that case. But I believe it's MBBS thing. Water diarrhea clause, bloody diarrhea clause. And these are the specific treatment of this different condition. Among them, if you ask me which are more important, giardiasis is like very important. Giardiasis, chronic diarrhea, steatorrhea, Aboriginal child brought because of that situation. Diarrhea, long history of diarrhea in Aboriginal children with foul smelly stool. So this is the idea treated with metro, very popular in the exam. Salmonella tested, and also traveler's diarrhea, that E. coli one is also often tested. And amoebic one has been tested alongside cholangitis is another. During the surgery class, I'll tell you. You can write near to this one like a cholangitis. Okay. All right. And typhoid, I would say nice to know, but I have seen question coming. Cholera, never I have seen any question coming. Okay. Is it clear about that? The basic diarrhea ones. Now we will proceed into another diarrhea case, which is a inflammatory bowel disease. This is actual 5-star for the exam. Other than the Giardia, this is the actual big 5-star for your exam. Do you also want me to show you intubation period chart? Actually, guys, are you familiar with intubation period chart? Like diseases with short intubation period, diseases with long intubation period, because often these things given in the AMC as a duration. Okay, diarrhea, these hours, diarrhea, this duration, and we have to very quickly pick up from the exam actually. Right. Let me see. Let's see. Okay, I have few. This one I think you need to take screenshot, guys. This one I think because this is not a separate note, it's just a collection. So these are like a very short incubation period. You see this, guys? Toxin input less than 6, Bacillus and Staph aureus. Some cases Salmonella can be also you can put here actually. Some books say Salmonella also can be here, even though it is put in here. But say example often, did you know that the chicken we are eating day to day? Yes, chicken we are eating day to day. If you do the marinated chicken overnight, and if it is not restored properly or while processing it, I mean processing of the chicken, if it is not clean, it can lead to salmonella. So chicken salmonella. Anyone remember this chicken salmonella? Yes, quite a common. Great. There's another special type of diarrhea, Clostridium difficile diarrhea, which will come in some of the pediatric class actually. Yeah, this is Davidson table, my dear. So Clostridium difficile diarrhea, antibiotic associated diarrhea. Some antibiotics can lead to diarrhea as well, right? Which is also known as the antibiotic associated diarrhea, like amoxicillin. Like there was a popular question in exam: a child with a ear infection, blah blah, and you give amoxicillin, and after that the kid is having diarrhea. What kind of diarrhea is this? Is a difficile diarrhea? Yes, pseudomembrane. Yes, syndrome colitis, Clostridium difficile. Great, wonderful, guys. So that is another type of diarrhea you need to remember. Children can have rotavirus, and you can see long intubation period. This is another important. So very short one is important, and also long one is like a Giardia. Also amoebic dysentery. So probably that's why these two are very popular in the exam. Okay, is it clear, everyone? Good chart, right? I'll show another chart actually. Another Davidson chart. This is for the travelers. Less than 2 weeks. Less than 2 weeks. Some condition which can happen less than 2 weeks. This is very bizarre and difficult. I think this one is much easy, but it's still, yeah, less than 2 weeks. You can take a screenshot or you can check in Davidson later. 2 to 6 weeks. So uh, less than 2 weeks, like viral fever, uh, some things like typhoid. Yeah, a lot of things like that. Acute conditions. Okay, these are Salmonella, Shigella. These are like less than 2 weeks. Whereas 2 to 6 weeks, like malaria, TB, all the chronic things like liver conditions. Yes, trypanosoma. Some can be even more later, even some variations of malarias, HIVs, yeah, rabies, much late presentations, schistosomiasis, African schistosomiasis. Yes. All right. Some diseases are overlapped given in two places, like malaria given in two places, because there are different variants are present actually. Like hepatitis, a bit after 2 weeks actually. Okay, I'll talk about some related to traveling things, but not today. It will be too much for early time. Some other day we'll be talking about some of the traveler related condition. For now, remember the E. coli one. Traveling related, I'll give you guidance in some other day. Okay. So far, is it clear, everyone? These two charts and the last one. Everyone took screenshots? Number one, number one, number two, and number three, guys. I'm just trying to make your life a little bit more easy. Eventually, you have to remember these things, guys. All right. Just saving some of your time. Otherwise, here, there, a lot of things. Okay. Another very important major thing, inflammatory bowel. What comes in your mind when I say inflammatory bowel disease, guys? Two things, ulcerative colitis, Crohn's, but few features are common in both of them. What is that? One is a diarrhea. There can be bloody diarrhea, right? Diarrhea and mucus, often diarrhea and the mucus, right? They'll give you incomplete feeling of defecations. If it is inflammatory bowel disease, is it only GIT condition or there will be non extra GIT conditions as well, guys? Repeat, understand the question. Is it a multi-system disease? Is it a multi-system disease? Even though diarrhea is the key, so GIT and extra GIT conditions. That's how you will find a lot of charts in Davidson as well as like the rheumatoid arthritis. Someday we'll learn. So not only articular, but lot of extra articular conditions actually. Okay, so here is the thing about the ulcerative colitis. So you can see few things: recurrent attack of loose stool, diarrhea and mucus, diarrhea and mucus. Okay, and of course, abdominal pain. And a special line I took from an AMC recall, area of friable mucosa. This is the exact line given in one of the question, but I found it in another book, but it was not present here. So area of friable mucosa, this is important for ulcerative colitis to remember. Okay, we'll get there shortly. Ulcerative colitis can increase risk of cancer, bloody diarrhea and mucus. Of course, we'll do a lot of tests, barium, endoscopy, a lot of tests, lot of researches goes on ulcerative colitis and Crohn's disease. Recurrent diarrhea in young, blood, mucus, GIT and extra GIT features. Abdominal pain, diarrhea, same thing. If you differentiate these two, this one has a more cobblestone appearance. This one is a bit more narrow intestine. Do you agree, guys? Like ulcerative colitis cases, the intestine, because it is called transmural. If you want to add extra pathology word, this Crohn's disease is transmural, means all four layers are involved. So the thickness increased. So it's more narrow. So this brings us to the point obstruction is more common in which case? I repeat, this brings us to the point obstruction is more common in which particular case? So it's more common in Crohn's cases, because it's more narrow lumen. Narrow lumen, more chances of obstruction. Narrow lumen, more chances of obstruction, more chances of fistulas. Okay. Their drug treatments are very important. You see, sulfasalazine is the mainstay of the treatment. Do you agree, guys? Sulfasalazine is a drug, it's a very powerful one, sulfasalazine. Uh, do you agree? A lot of this big disease often treated with steroid, like even rheumatoid arthritis cases, many chronic skin cases at some point, or acute flare-up cases, or many autoimmune disease cases, you need to treat with the corticosteroid, compare and contrast. Okay. Now, if the disease progresses even more, sulfasalazine may not be enough. We go with the azithromycin. There is provision for the surgery, but for AMC, we don't need that part actually. Surgery is reserved for the complications. Say if for the Crohn's there is obstruction or other thing, you have to go for surgeries, right? So azathioprine is another one. Now let's get into our, should I say? Okay. So if you open up like the medicine, everything has some notes here. Given some notes are given here, as you all can see, like inflammatory bowel disease, irritable bowel syndrome, Zollinger, GERDs. You'll find a lot of notes, relevant or important note, I would say. So let's open this one, inflammatory bowel disease, because it's big actually. So some people get confused because if you open Davidson, it's like a 10, 12 page of Davidson, inflammatory bowel disease. So often a lot of doctor, they confuse, doctor, should I study? They get scared. So that's why this notes makes your life a little bit more easy. Now, you see, this is first of all always think inflammatory bowel disease. Now, word bowel is there. It's can be related to diarrhea. Diarrhea and the mucus, these are more common already mentioned. Inflammatory means sign of inflammation there. So there will be fever and this, that thing is there. Because there is problem in the bowel. Is it possible that you will lose weight? What do you think, guys? Of course. So there's a possibility because bowel involved. Yeah, I remember like, very rarely I have like diarrhea incidents, but I think 2 years back I had one time. So it was like a 2, 3 days episode, but I lost 2 kg weight that time. So that's like a beneficial side we can say for diarrhea. But anyways, but weight loss is quite common in. So if there is a chronic diarrhea, you will start losing more weight. At the same time, the vitamin and minerals, those will be also affected. So you will start feeling weak because your appropriate vitamin minerals, these are not going well. As like the same, when you do a lot of intensive workout, gym and this, that, your normal day-to-day life eating is not enough. So sometimes you need to take supplements like multivitamins actually. Okay. Now here you go. Is it a acute? No, it's a chronic case. Chronic case in the GIT and associated with these two conditions, common feature abdominal pain, diarrhea, bleeding, weight loss, reduced appetite, change in the bowel habits actually. But change in bowel habit is more confined or more related to which disease? Altered bowel habit and weight loss. More related to what? Altered bowel habit and weight loss. Related more with colon cancer. Altered bowel habit, weight loss, some cases anemia, more related to colon cancer. So often we rule out if there is any colon cancer or not. Okay. So in IBD cases, the main state can be sulfasalazine is the mainstay. Chronic condition is so long time follow up and this that needed. While still there is no such particular cure, so emotional support and this that are needed. So some John Murtagh things I also added here so that you can go for a quick revision during the exam. It is interesting that in ulcerative colitis, people can develop cancer after uh, 7 to 10 years. It's a possibility, not like it will happen. Now, here I'm telling this thing. See, ulcerative colitis bowel size versus Crohn's disease bowel size versus normal. So normal ulcerative colitis, lot of more ulcers. Crohn's disease, transmural, so narrow lumen, more chances, thickened wall, so more chances of obstruction, and it gives rise to cobblestone appearance. Okay, so 6 notes, it will be easy for you. Yeah. So Crohn's disease, pain, diarrhea. Okay, same thing. So summary, important for MC, treatment, initial, mainstay, always this thing comes, sulfasalazine. Acute flare-up, corticosteroid, refractory case or treatment failure case. They'll give you scenario and they'll say this, that we tried, not working, as a thioprin. And here is a big differentiating chart actually. It's a very interesting point. Now, some of you could be smokers as well. There's a good news for you guys that if you do smoking, you probably don't have the inflammatory bowel disease. Very interesting point. Now, maybe some of you are happy right now, like uh, at least some benefit of doing smoking actually. You know, a long back, I know I was teaching this thing to medical students. At that time, I was teacher in China. So some of them, in cultural program they made, Dr. Shahriar said that like smoking is good for life. I know I was also thinking, from where the hell I know I have said smoking is good. So it's because just, I put that line that, smoking is good for because a lot of people are smoking there actually, a lot of my students. So I was also telling I don't smoke and this, that, and sometimes to seize their packets as well. So like, but that's a like fun actually. And the some of the Chinese security guard, they call them susu or something like that. So I used to give them, okay, you guys eat this packet actually. So, anyways, fun things. Those of you who went to China for med school, you can understand like what I'm saying actually. I mean, they like to smoke a lot in China. Anyways, so lower incidence smoker, and they put that as a portrait in a cultural program in a fun way actually. My vice dean was sitting next, like he was looking at me. Did you say that? No, no, it's like just making joke. Anyways, so GIT, extra GIT features, and just have a look. At the end, if you see the summary table, you will feel better. Okay. Everyone clear about the inflammatory bowel disease? Do we need to again go through the John Murtagh? I think we're good with it because we're almost at the end with the very last topic. It's very easy peasy. Irritable bowel syndrome. It has also bowel related problem. But what else? Young female here. Young female here. And alternative constipation and diarrhea episode. Alternative constipation diarrhea episodes. Okay. And there can be bowel habit change as well. So alternative constipation diarrhea, and they might also have some psychiatric problem in some cases. Some cases. So here is the thing. I think better you check this thing from the note actually as well. So irritable bowel syndrome, functional disorder, abdominal pain, discomfort, and bowel habit change. Pain, bloating, bowel habit change, diarrhea sometimes constipation. That's why alternative constipation and the diarrhea. It's a unique situation. It's a chronic disease, actually. These are some of the common features. Sometimes constipation, sometimes diarrhea, some cases mixed. Feeling incomplete bowel movement. This is important. Incomplete. I mean, they feel like it's not complete. All right. Okay. So you will see this um, irritable bowel syndrome. So abdominal pain, bloating, these are common. Sometimes constipation and diarrhea. Relief by bowel movement. So I remember one time this came in the exam. This line was then it actually when they go to toilet after a bowel movement they feel better and relief by changing the bowel habit as well. And here's the treatment suggestion. You need antispasmodic drugs. I repeat, irritable bowel syndrome demands antispasmodic drug and also tricyclic antidepressant, which is a drug related to depressions actually, because these people have psychiatric issues actually. All right. And constipation dependent IBS, fiber, and some of these drugs, diarrhea dependent cases, these particular drugs. Okay. All right. Great. Everyone, all good so far? Everyone so far happy? Okay. Um, Today's extreme last topic, but this is also actually a pediatric topic, honestly. I don't know, should I mention that this one here or not? If you have patience, I'll just take 1, 2 minutes, but this will definitely come to pediatrics as a major disease. Um, this one is like a most easiest one, and this category of celiac disease is comes under malabsorption. Let me tell you why malabsorption. It's interesting. It affects our villi. This is our normal, like this villi, and here in this case, the villi are like this. So flat villi or villus atrophy, we call it. Now, if you have villi affected, villi is important for our absorption. Uh, will you have the same like before? No. So there is malabsorption. So a lot of vitamin, mineral, these particular things get affected in celiac disease. So they usually have problem with particular foods, which is called the brow, right? Barley, barley, rye, oat, and wheat. If you eat them, it goes to the villi area, it affects the villi and gives rise to symptom in GIT and some also extra GIT symptoms, some cases. Okay, so this is the celiac disease. Is it common in Australia? Very common. That's why it's popular, the questions. Now, many restaurant mention this thing in their restaurant is as what? Gluten free. Have you heard this term? I'm sure you do, all of you. Gluten free. That also has become a marketing policy now. Asian also has more gluten related problem than Caucasian probably. So gluten free diet is important. Asian also have lactose related problem a lot. Do you agree? So in that case, we should avoid the milk and milk related products. I mean, less or lactose free milks in that case. So there's gluten free diet. So gluten free biscuit, gluten free diet, gluten free this, that are very common. Now, what is the investigation which is very popular for the exam? Any idea? Any guesses? Initial, next, and also best. So initial is a what is it? Anti-gliadin antibody, anti-endomysial antibody, and best is a duodenal biopsy. Yes. Okay, so these are some of the names: initial, next, best. And symptomatic myself sometimes and anti-transglutaminase. This terms is also given. So anti-gliadin, anti-endomysial, and duodenal biopsy. So summary: how to prevent celiac disease? What is the mainstay of the treatment in one line? In one line, that is actually the treatment. Answer: avoid the gluten. So gluten-free diet. Avoid the brow, gluten-free diet. Extreme cases, you can go for Dapsone. Okay, so treatment, gluten-free diet, and extreme cases, Dapsone. Okay. In pediatric, when you read celiac disease, we'll also tell you about the cystic fibrosis. Okay, cystic fibrosis is also important to remember actually. Investigation: anti-gliadin antibody, anti-endomysial antibody, and duodenal biopsy. Let me show you from the John Murtagh. Sometimes we call John Baba. So same thing, GIT and extra GIT symptoms. They can remain asymptomatic as well. Very common in Australia, gluten-free diet, So these are the features: diarrhea, weight loss, and lot of vitamin deficiencies. Yes, and here these things are given. So how to confirm duodenal biopsy to confirm? So anti-transglutaminase is like the second component test, and anti-gliadin is also initially you can do. Management, brow control. Celiac disease can be associated with skin lesion, dermatitis, herpetiformis. Please mark this one, 418 page. So 417, 418. It's a mostly a pediatric condition. I will teach this one again in the pediatrics. All right, guys, it's a long day. Thank you so much, guys, for attending this session. Thank you for long hours. Thank you for staying. I'll upload the recording tomorrow. And thank you so much for joining. I mean, we'll go one step ahead, one step at a time, and you all will be fine. Trust me. I mean, many gone through, but you just have to attend the classes nicely, guys. You just have to attend the classes nicely, guys. This is very, very important. I'm showing that investigation part again, and anti-gliadin, anti-endomycin or anti-TANS like glutaminase, second, and finally say duodenal biopsy. Thank you so much, guys, for attending the session. And we will some of the things will come in the surgery. Now is a time for mock. So what I will do in our group, I will post a um, PDF of questions. So you will take a pen and paper like this. So what you will do, it's a very manual old technique. So you will take a pen, paper, and what you will do, like up to like whatever the numbers given, like 1 to 10 or 1 to 12, and then say one answer A, two answer B, this, that, and the answer sheet will be provided in the same group after like um, 30 minutes. So you see that one, correct by yourself and post the answer keys actually, right? Don't have to be panic. It's a learning because it's so early actually. Okay, so in future we'll have bigger, longer computerized tests. So don't worry at all actually. Okay, so don't worry. It's just to check and keep you into studies actually. Yeah. So I'll be providing that uh, file now. I'll be providing that file now. It's on respiratory. So how much you have finished, you can take now. If it's too late for you, like New Zealand and the Fiji, you can take it tomorrow as well. No problem. So there'll be two files will be uploaded. One is the question file, one is the answer file with explanation. I'm uploading it now, my dear. So check the um, particular group, or I'm sending the link. No worries, guys. Don't be panic. A lot of doctors panic a lot actually. So don't worry at all actually. Okay, so I'm just posting our group link first of all, where to check everything. Some people ask about, yes. Yeah, you can take tomorrow. If it's too late, you can also. So this is our group where I will be posting the file right now. Initially the question, and after 30 minutes the answer. So time to time is always fine. If you can take it, it's always good actually. If you can do time to time, it's always better. All right, so I'm going to post it now. Okay, so please confirm me in the comment section that if GIT mock has been posted or not. You can check with another device. Answer is not posted now. Answer will be posted, after like a 30-35 minutes. All right. Okay, let me show you the link, how it looks like. Let me show you the link, how it looks like. Okay, now 1 minute again. Yes. There's a lot of things, discussion, member events. So, oh, okay, okay, sorry about that. Just give me a second. Ah, my bad. I think I should go for the respiratory. Just give me a second, guys. Sorry about that. Please confirm if you find the respiratory one. I just now posted. Okay, I'm scheduling the answer case. Wonderful. Yes. Please confirm if I posted the respiratory. Yeah, respiratory done now. That's perfect. Let me remove the GIT. Don't say it. That will be probably for the. Yeah, I removed that one. All right. So thank you so much, guys, for attending the session. I hope you like the GIT. Go for the exam if you have energy left. Otherwise, you can take it tomorrow morning. Don't see the answer sheet. I mean, before actually. Yeah, I already mentioned, like, you can go to the batch 62 group. Take some time. You can refresh your page. You will find it. Okay. Take some time, guys. Take some time back. Refresh your page. When you refresh your page, it will automatically come in your screen. As you can see, it's already there. Yeah, here we go. I'm giving a shout out here. So tagging everyone. Yeah. So you'll see a notification or something. Yes. See? Or you can go to file section. You can go to file section. Yeah. And find it here. Respiratory question. Yeah. Yeah. I will delete that JT, of course, because yes. All right. Okay, guys. So thank you so much. All right. It's about self-practice, guys. We're not kids anymore, right? I mean, you will not see the JIT answers, I believe. Thank you so much, guys, actually. Yeah. Take some rest. I mean, we all need some rest. After taking a little rest, you can go for the. So it's more like self and computers one will come in future. So don't worry. I'll see you guys there. Yes.